Now we're recording, so I'll say hello again. Good afternoon. This is the April meeting of the Universal Healthcare Commission. We are being recorded. The recording will be posted on the commission's webpage. That usually takes a couple of days. I think also TVW is streaming this meeting live. I'm not sure about that. And Vicki Lowe, who is right here to my left, the chair of the commission, will call the meeting to order. Good afternoon, everyone, and it is now 2:01. Call this meeting to order. It's the April 17th meeting of the Universal Health Care Commission. And please let us know if you can't hear. We're in the room with the mics in the ceiling and just making sure our voices are projected in that. So as always, I want to begin by giving a land acknowledgement. So I would like to begin by acknowledging that as we gather today, we are all on the lands and ancestral homelands of Indigenous people. We honor Indigenous people despite being removed from lands where they lived, hunted, gathered, practiced ceremonies, and cared for their community members. We honor Indigenous people and tribes, whether officially recognized by the United States government or not, as they continue to care for these lands and their community members. As health professionals, it is important that we also acknowledge the impacts of the removal from traditional lands of children stolen to boarding schools and of the oppression of culture and traditional ways of life on the health of Indigenous people throughout the country and in Washington State. As we work to improve health in Washington State, it is imperative that we address these inequities of the past by understanding their impacts of the present. I invite each of you to learn about and understand the true history of the Indigenous lands where you reside. And I'm looking for a volunteer to provide a land acknowledgement for our June 11th meeting, so let me know if you're interested, and I'm happy to help if you want help with that. So not Jane.
Not Jane. I have a good excuse. My son's getting married.
That's it. Congratulations. So you know how to get a hold of me if you can. And then I'd like to give a warm welcome to everyone joining us today's meeting of the Universal Healthcare Commission. And if you go to tab 1 in your book, do a brief overview of the agenda. Roll call is our first item. As a reminder, we like to incorporate a check-in question to help everyone get to know each other. Today's check-in question is, what's a little thing that makes you extremely happy? After roll call, we will vote to approve the February meeting minutes, then open the floor for public comments. I think we have a lot of comments today, so we might looking at how much time we have. Following public comment, we will review our 2025 work plan and then include a conversation about whether to consider governance earlier in the design and process based on some public comments that we've received in the past. After the work plan update, David DiGiuseppe, who will be joining us from his vacation in Spain, will have a 2-part presentation. First, he will update us on the March FTAC meeting, then will present results from the benefits cost analysis and the FTAC's recommendation for the next steps. Hope that will be a very good conversation with David. After a short break, we will return to that content, and Liz Arjun of HMA is here, and she will lead us in a discussion about further directions and how the FTAC can support the commission's work. So now back to Mary for roll call.
Thank you. Good afternoon, everybody. Before we begin roll call, just want to note with recent state elections and changes in the legislature, changes in leadership at various state agencies, we realize that there are some vacancies on the commission right now, and we are working with the governor's office and the House and Senate leadership to fill all the vacancies, hope to have those filled soon. So now I'll do the roll of the members who are here, the members we have. Please, when I call on you, please unmute your microphone, let us know you're here. And then today's get to know you question is some little thing that just makes you kind of disproportionately happy. So first on our list is Chair Vicky.
I'm here, and I think the little thing that makes me disproportionately happy is my grandkids.
I
Spending
think that's a
time
big
with
thing. Vidisha.
Sorry, I'm here. It takes a little time to click on that on mute button. I don't know. There are so many little things. Spending some time with my dogs or my kid, they all make me very happy.
Charles.
Yeah, yeah, I was just thinking about that earlier today, and I have an 11-month-old, and just her smile is just the best in the world, and it just melts my heart. So I can't be more thankful for her getting ready for her 1 year birthday soon.
You. Dave.
Hi, everyone. Dave Eisminger here on behalf of the Healthcare Authority. And I recognize my disproportionately happy thing I'm about to say represents a lack of work-life balance. But I really nerd out over the legislative process, and I love watching TBW all night long. And the other night, there was a shout out to the 10 people on TBW, and I know who at least 2 of those 10 were.
Gosh. R. Way to own it. Jane.
Hi, I am not geeking out over work. Jane Byers, Senior Health Policy Advisor, Office of the Insurance Commissioner. And what makes me happy is when my phone rings and it either says Eric or Kate. My children. They still love their mommy.
And Joan Altman of the Health Benefit Exchange was not able to join this meeting today, but Laura Kate is here in her place. So Laura Kate.
Hi, everybody. Laura Kate Seichkin here for the Washington Health Benefit Exchange. The spring sunshine makes me very, very happy. So I'm a happy camper today.
Representative Joe. We did hear from his office that he might not be able to join us today. Representative Joe.
He is on the floor.
Okay. Mohammed.
Thank you very much. I'm glad to be here too. And hi everybody. Little things that make me. There's a lot of them. I have my kids. Thursday, since the pandemic, I think it's the one day that I always been working from home. It's not by design. It just happened. And today I was hanging out with my 3-year-old and 4-year-old almost, and it just made me realize how happy they make me, despite all the work.
Nicole.
Hey everyone, something that makes me happy, my kid and my dog, and how happy that my dog specifically is to see me when I arrive home.
Omar. Omar let us know he might be joining a little late today. I don't think he's here yet. And Stella. Okay, thank you all very much. Turning it back to Vicky for a review of the meeting minutes.
That's 8. We have a forum. Please join me in turning to tab 2 in your book. And the recording of our last meeting is posted on the Commission's webpage. And we will vote on the approval for the February meeting minutes. Is there any discussion or changes? If there are none, I'm willing to accept a motion.
Second.
Moved by Jane Meyer, seconded by Dave Smiger. Any further discussion? Okay, all those in favor say aye.
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 Any opposed, say nay. All right, motion passes. Now go to tab 3. Since our last meeting, we have received 4 written public comments, and they're in top 3. These comments include requests for the commission to support the Washington Health Trust Bill and express support for universal health care and single payer system in Washington State. Commission members received these written public comments as part of the full packet meeting last Wednesday, allowing time for review. If you have not signed up and would like to provide public comment, individuals can also sign up to provide public comment during this meeting. If you have not signed up and would like to provide public comment, please use the Zoom feature to raise your hand. Harry will call on you after we hear from those who have signed up. When you are called upon, please start by stating your name and the affiliation. We encourage comments to focus on the materials and topics being discussed today. For members of the public that are planning to speak on addressing governance sooner, the commission is especially interested in hearing more about why. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. To ensure that everyone has a chance to speak, there is a limit of 90 seconds per person. As I mentioned, we have a long list today, which may need to be reduced if we get closer to the time limit for public comment. We will be displaying a timer as a reminder of the limit. There it almost is. When the timer stops, please stop your public comments. Mary, would you please start with the names of the individuals who have signed up to provide comment?
Sure. Folks will provide comment in the order in which they signed up. We will move you over, so please accept the panelist link. And there may be a couple of seconds where you don't hear us and we don't hear you, but we'll come back and we'll be able to hear you, promise. So the first person who had signed up is Jordan. Jordan, my apologies. I'm not sure how to pronounce your last name. But I think Jordan is here.
Yes, I'm here. Can you hear me? Okay, I apologize. The timer disappeared, so I hope I can stay within my time limit. I'm Jordan Despain. I'm a family doctor with Confluence Health in Wenatchee, Washington. I'm also the certified medical director for family medicine, so I work with lots of the family medicine departments in our organization. And I wanted to take this chance to offer my support for what you're working on, in particular, whole Washington and what they have proposed. I just learned about it recently, and I'm really excited about what they've proposed in order to solve a lot of the problems that I encounter in my work as a family doctor. I collected a couple of statements from some of my patients in the last couple of weeks about issues that go on that could be solved by whole Washington or a different universal healthcare plan. One of my patients had a knee injury 10 years ago and never sought care because he was a small business owner and didn't have personal healthcare coverage, and came to see me recently because his knee was bothering him. And when I examined him, I could tell that he had torn his ACL. And so he went 10 years with no ACL and worsening knee pain that could have been addressed a long time ago had he had healthcare. Another patient of mine had very well-controlled diabetes, but insurance changed and was no longer able to get the medications that she had been prescribed. And so is likely to not have well-controlled diabetes. Another patient of mine with type 1 diabetes requiring insulin.
Mr. Spain, can you wrap up? We're at 90 seconds. I'm so sorry.
Okay. Not only myself, but also there are surveys that show physicians in general are in favor of universal health care. I think it would be a good thing for the medical system, for providers, and for patients. Thank you.
Thank you. The next person is Scott Sutherland.
Hello. Hey, my name is Scott Sutherland. I'm a freshman at the University of Washington. I'm originally from Bellingham. I'm here studying biochemistry with a minor in public health, and I'm a member of Washington CAN, with the goal of becoming a pediatrician one day. And I'm commenting to reinforce the necessity of a single-payer healthcare system and encourage the commission to address governance early in its system design. Since 1980, when 138 countries came together to affirm a cooperative goal of health for all, at least in the United States, public health has since declined, while healthcare has ballooned to over 20% of GDP, causing foreclosures and bankruptcies for families and endangering our state and federal fiscal health. To be honest, I want to care for patients, not burn out on paperwork, to treat patients of all backgrounds and not worry about differential reimbursement rates or sparring with insurance. We have models from across the globe to inform us, as well as previous work done by the Universal Healthcare Work Group and proposals like the Washington Health Trust to utilize. With the dedication of everyone on the commission and in the community, together we can build an affordable, efficient healthcare model that promotes public health for every community. But we need to take the first step in determining governance and architecture of the system. And that's why I'm encouraging the commission to promptly address governance. Thank you.
Thank you. The next person who signed up in advance to speak is Dave Chase.
Thank you. Hopefully you can hear me. So I've authored 3 books on healthcare transformation and lead organizations that have proven the best health plans in America cost 20 to 50% less per capita, making our goal here much easier if we tackle that. There are 3 crucial insights that I found in this work. First, governance works best at a scale of 25 to 500,000 around the world. We have community-owned health plans in Alaska, Ohio, and social cooperatives in Italy that have proven remarkably effective and could be very helpful for us. Number 2, healthcare isn't inherently expensive. Clinicians only receive 23 cents of every dollar ostensibly spent on healthcare. And what we found is we're already investing more than enough money to not only fund a world-class healthcare system, but also address the social determinants of health that are driving 80 to 90% of health outcomes. We recommend on the path to universal healthcare, tackle universal primary care and remove the extreme waste that's in the system that I detail in the letter that I submitted after the deadline. And we work in the ERISA area, which is a big obstacle. We believe we can turn those obstacles into opportunities. And I'd just wrap up with every community has a mighty river of healthcare money flowing from our pocketbooks that should work like a water cycle, replenishing our communities, not extracted to corporate pipelines. So appreciate your attention to this great effort and the great work you're doing. Thank you.
Next person is Raleigh Watts.
Good afternoon, commissioners. Thank you so much for your service, and a shout out to our elected officials. Washington State urgently needs an equitable and universal healthcare system. I want to relay something that happened at the FTAC meeting last month that provides an example of why we need to talk about governance first. In grappling with various options for cost containment at the last FTAC meeting, some members expressed that it's hard to talk about these details until decisions have been made about governance and overall system design. This is because cost containment could look different in a single-payer model, a multi-payer model, and its implementation will vary depending on how the system is designed and the ultimate accountability. So I call this comment out as a rationale for why the Commission should make the big picture decision about governance and system design first. It'll be a lot easier then to talk about costs, services, and eligibility, which can flow from the bigger architecture. You know, here in Washington, we like to compare ourselves with Oregon, of course. Oregon is ahead of us in its development of a universal system because it addressed governance earlier on in their process and is transitioning from a commission to a trust board. As noted in your packet, the Washington Health Trust provides one model for how governance could look, and that's worth looking at as a starting point. We at Whole Washington would be happy to share more about this when helpful. Thank you for your service.
Thank you. The next person is John Godfrey.
Hello again, commissioners. My name is John Godfrey. I'm the program manager for Washington Can and a small business owner in Seattle. A big plus one to two of the main points that Raleigh just made in terms of the justification for going to governance first, so it could help out the FTAC, and it will just provide more direction. But you've heard from members of Washington Can over the last few years, like Scott, who've been deeply impacted by healthcare dysfunction. Apple Health has been straining for years to cover patients due to low reimbursements and narrow networks, even before the current state budget crisis and the federal uncertainty we face. Premium subsidies for the exchange for 2025 ran out in November last year, I think it was. As a result, patients will continue to bear the burden of this dysfunction by increasingly foregoing care due to high prices, increasing our long-term problems. As a small business owner, I have the privilege to provide gold level plans to my staff. Thus, I've borne the burden of high prices. Over the last 2 years, we've seen annual increases in premiums up near 20%. And that was before the economic and macroeconomic uncertainty. Again, small business owners are facing, if nothing has changed here, we are going to see more and more small business owners pushed onto the exchange or Apple Health making our problems worse. So just to conclude, I really urge the commission to take on governance more soon so that we can make some headway towards the major problems that we're facing in our healthcare system. Thank you very much.
Thank you. And the last person who signed up ahead of time is Andre Stackhouse. Is Andre here? Oh. Yeah, is that, maybe Andre's logged in as whole Washington? You know what, why don't we go to a raised hand, and then Andre, if that's you, whole Washington, please let us know in the chat. But I know we have some hands raised and we have some folks in the room.
There we go. Hello, yes.
Oh, there you
This
are.
is
Okay,
Andre.
hi.
Sorry, I'll just quickly rename myself. And I will go on camera. There I am. Good afternoon, everyone. Thank you so much for providing this space for public comment. It's been a while since I spoke to the commission, so it's great to be back. And a number of things have happened since the last time I spoke to the commission directly, including the publication of the Washington Health Trust Analysis Report. And the report, identified no points of misalignment with Washington Health Trust's system design, but also was not complete in its analysis and unfortunately was written on a previous version of the Health Trust. Since then, we've held over 30 town halls across the state of Washington. We've incorporated feedback from that report as well as from the community and worked with Senator Hasagawa on a new version of the Washington Health Trust, and we expect a completed report by the end of the calendar year. And we offer our support in running that analysis. We also are happy to report the passage of Senate Joint Memorial 8004, which has deepened the state's commitment to universal health care and requested federal partnership in this. And in looking to 2026, one way in which the commission can help move this forward would be to help the Washington Health Trust in receiving a public hearing in the relevant policy committees. It's been introduced into the House, into the Senate, to record co-sponsors, including members of those committees. And we are going to be pushing for a work session this summer, but we hope that by 2026, it can be in a position to receive a public hearing that does not have to be a full recommendation from the commission, but instead a request on the basis that it would help the commission with its work. Thank you.
Thank you. Before we go to the raised hands, we have a raised hand in the room. Do you want to make a comment?
Yeah, I don't know if you wanted to make a comment. I got your first.
Can you stand up and you gotta yell at the ceiling?
There, yeah.
And if you can give us your name, that'd be
over
great.
there. Okay. Good afternoon. My name is Hashmi. I'm a graduate student studying global policy at the University of Washington, and I wanted to sort of comment on the kind of looking at different healthcare systems. Like, I lived in the UK for quite a while, and so studying that healthcare model, how they transition from private to public healthcare. I was wondering in the United States, or specifically in Washington, what would the government be able to do? Like, what's the relationship between private enterprise and government kind of power in like nationalizing hospitals and that sort of infrastructure? And I'm not sure how that works. I know there's a Medicare for all debate here, but I was wondering how that process would happen, and would that raise any problems in sort of, or constitutional problems, or private property being taken for public use? I don't know if that would be unconstitutional. I know the Constitution is a big thing here. So yeah, I don't know if this is a question answering type of kind of forum, but that's kind of what I have to say. And yeah, thank you.
I don't think we have any other comments from the folks who are here in person, so we can go, we see two hands raised. Marcia. I think Marcia's next. Do I have that right?
Okay, let me unmute.
Hi.
Hello, everybody. There I am. Okay, I see me too, and you. Thank you for this opportunity to comment today. My name is Marcia Stedman. I'm speaking as a current board member and past president of Healthcare for All Washington today. Thank you for listening to the stakeholders who have urged the topic of governance to be considered much earlier than in the work plan than originally. We are pleased to see this topic included on today's agenda and urge you to focus on designing governance models earlier in the work plan for two key reasons. Number one, the governance structure will have an impact on the overall universal healthcare design. Will it be an independent trust fund? Will it be a separate board of trustees like the Health Benefit Exchange that relies on state dollars but can make key policy decisions without going to the governor? What ability will the governing entity have to contract with entities that deliver healthcare services, oversee benefit design, access to healthcare, and workforce needs? And number two, the governance structure will also be key in gaining legislative and public support. Legislators will want to understand their options and what control they have over policy and budgets. The public will want to know how responsive the governance structure will be to consumer concerns and what their role would be in the governance structure. Healthcare for All Washington understands that each element of the work plan is important to the overall recommendations. We firmly believe that having a basic governance framework earlier in the process will help with clarifying other design elements and will help the legislature and public to see the vision and ultimately support it. We look forward to moving on this as quickly as possible. Thank you.
Thank you. And I think we had one more hand up, and it was Maureen.
Mute, okay. Yes, I don't know if I'm on air yet.
Hear you.
Okay, great. My name is Maureen Brinkland, and I want to thank the commission again, both for your work and for taking these public comments. This has to do with governance, but it's a little story first. At the last FTAC meeting, a public commenter asked why the Milliman actuarial study did not address administrative costs when it was addressing costs. The Milliman rep responded to this question during the meeting saying that Milliman was not asked to include administrative costs. In many of the oft-quoted studies comparing the U.S. healthcare systems to systems in our peer nations, as well as those of poorer countries, the U.S. is consistently the outlier for both high costs and worse outcome rankings. The poor showing on both outcomes and costs turns out to be rooted in the high percentage of spending allocated to administrative overhead in the U.S. systems. Reining in, or at least controlling administrative costs, is often pointed out as the magic bullet that could bring U.S. healthcare costs and outcomes in line with other countries' lower costs and better outcomes, including longer life expectancy, fewer deaths from treatable illnesses, and better maternal and early childhood outcomes. Seems like information provided by an actuarial study of administrative costs is essential data in developing a governance framework for a successful financing system that you are working on. Is another Milliman study that provides that data in the realm of possibility? Thank you very much.
Thank you.
I want to thank,
Oh, go ahead. Yep, we're done.
I want to thank everybody who gave public comment today. Do you want to? Okay.
Did we have, I don't think we had another comment.
And we appreciate you taking the time to share your thoughts, and we will take your input into consideration as we move forward with the commission's work. And I think the team would still be in the room, but you know, the process for public comments is like a back and forth conversation. Take the information and like build it into the work we do. So we apologize if that's awkward for people, but that is the process. Yeah. Now Mary is going to talk to us about our work plan update.
If I go to the next slide, I'm going to start out talking generally about the work plan update, then move into conversation about governance, and then Liz will jump in toward the end and help lead our discussion. So if I could have the next slide. Here's the tracker that keeps us going that we've seen before. This is where we are in the essential phase 1 pieces of the universal system design. As you recall, transitional solutions are a little bit on hold, picking them up in the second half of this calendar year. So focusing first half of the year more on the universal system design. If I could have the next slide on it. There we go, the goals for 2025. This is repeating some things that were yellow on the previous slide. Complete the analysis of the benefits and services, develop recommendations for cost containment. That's something FTAC is working on now, hoping to bring their recommendations to the next commission meeting, and develop a set of recommendations for provider reimbursement and participation. As I said a moment ago, transitional, the interim solutions are on tap for the second half of this calendar year. So the next slide. Just to show where today's conversation fits with the tracker. The cost analysis report that David will be talking about later, David DiGiuseppe will be talking about later, that helps inform the discussion about benefits and services. Cost sharing is a part of that analysis discussion, and also provider reimbursement. So, you know, we divide this work into categories, but sometimes one conversation touches on a number of things. So that's why we put together this slide to show that we're making progress on all of our yellow ovals today. And the next slide. Our work plan. Again, this is a slide that's been updated recently, but it should be kind of familiar by now. Here we are in April, preliminary recommendation, benefits and services prioritization, and also some discussion of cost containment. If you look ahead to June, the next time the commission will be getting together, things are in red, dun, 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 dramatic red, and that's looking for some final recommendations. So the work will be going back and forth between the commission and FTAC. Here's the first half of the year. The next slide shows you the second half of 2025. Again, I always feel compelled to mention that those future topics are, well, we're not quite sure. They are future topics, and you know, some topics may slide a little later in the year and new things may come up, and that's why we left that a little blank for now, but I'm sure we can all find a way to fill that stuff in. And the next slide. Getting to the topic of governance. Thank you all for your comments about it today. Comments at previous meetings, also we're at the FTAC meeting. We've heard about this quite a bit. When it came up at the FTAC meeting, I know members very much appreciated the conversation, and also it is determining the order of things and when governance is addressed is more the purview of the commission than it is of FTAC, but certainly please, you know, continue to speak up in both venues. There's a little blue arrow down there that shows where governance is. Bottom left of this slide, it's in phase 3. But as we said, some recent public comment has asked the commission to consider addressing this earlier in universal design. So that's the conversation we wanted to have today. The next slide. So we went back to some of the earlier work plans and things and talked about what we mean by governance, and it's the governing structure that oversees the unified system. Goals are to make sure things are transparent, make sure there's accountability, and it's different from what we're calling infrastructure. Infrastructure is part of phase 2. So often when there are proposals for universal system design or existing universal systems, there are different governance structures. The example I pulled out here is from Senate Bill 5233. Board of Trustees, 17 members, and usually when the governance board, when there's a number of people, sometimes it's people from this industry, people with this lived experience, people with this expertise. This one happens to be 17. I read the Massachusetts bill earlier this week. Theirs is 29 people, but they just sort of follow a pattern here. So the next slide. And there's key considerations when you are thinking about your governance structure. And the two big questions are who administers the program and who regulates it. And the blue box are some possible entities. Again, we're looking at how other universal systems are designed. Could be an existing state agency, it could be a brand new state agency, could be a combination of new or a combination of existing or a new and an existing. There's a number of ways to put this together, and depending on the structure, it could involve the health plans. And that would be probably if we had a multi-payer model. So just depends on the structure that we land on, whether or not health plans are part of the governance structure. So that's the quick background. As we said, we are interested in having this conversation. So the next slide gets us into our discussion questions. And these are questions for commissioners to consider that we'd love to hear you talk about. I will read them real quick, and then I think I'm going to bump it over to Liz to maybe get us going a little more. The first question is the key considerations that we just talked about. Do those need to be resolved for the commission to move forward? And if the commission decides to consider governance earlier in phase 1, how is that going to affect the timeline for other parts of phase 1? So I'm going to kind of let those sit, and I'm going to bump it over to Liz and open it up to see if anyone on the commission wants to comment on any of this or any of these questions.
Just looking for hands after you've digested, so.
Or just unmute yourself.
Or just unmute
there we
yourself.
go, Vidisha.
Yeah, Vidisha.
Yeah, actually, I have a couple of questions. So since FTAC brought this up that it would help them if the governance is moved up, at least that's what I heard from the public comments. Where would it help? I am totally in favor of moving it up before the infrastructure, so before the phase 2, but I was hoping to actually go through financing that's listed under phase 1. So is discussing governance right now going to help with the calculations for financing?
I'm gonna ask Vicki to comment on that, on your.
I was wondering if David, did you beyond comment to what was said at FTAC? I'm sorry, I haven't listened to that meeting.
Yeah, and I could be, I heard in the public comments somebody saying that during an FTAC meeting, somebody said that the administrative cost was not, included because they were not asked to include it. And I'm assuming that that's what's related to the governance part because it's administrative cost. So I'm trying to understand moving governance up, how will that impact any of the things that's listed right now?
Hey, David, right there.
Yeah.
Can you see me, Liz, or hear me?
Yep.
Yes.
Okay. Thank you for the question, Vidisha. So I don't remember the exact comment that was referred to in the public comment. I can tell you that in the presentation that I'm going to be giving shortly, FTAC has described additional analysis of administrative expense that would help with understanding options for governance and and helping the commission prepare recommendations for governance. Does that answer your question?
Partially, yes. So, I mean, does that have any impact on the cost benefit analysis that you're going to present today, or the financing portion that is listed in phase one? So knowing the administrative expenses, I understand that's one component of cost benefit, and that could be, tacked on at the end. But does that have a bigger impact than just, being added or subtracted out of the current cost benefit analysis?
Yeah, so it's a great question. The analysis of administrative expense doesn't affect the cost analysis I'm going to present today, because what we started with was the medical cost. So the total cost of receiving and providing medical services. What it will help with is outlining options for the administrative costs that will then be layered on top of the medical costs and compared to the administrative costs of the current system.
Okay, got it. Thank you.
Yeah, you're welcome.
Just to clarify, Gary, my colleague, FTAC didn't say it would help them for the purposes of exactly what David said for this piece today. I think the three components that are in phase one that we're sort of going back and forth on, and you'll see in David's presentation, that really kind of we're looking at right now. The idea is to come up with, what does the commission want to say about these three pieces? What do the benefits look like? How do we want to reimburse, or how do we want to contain costs? Once you have that, you can talk about how it could be administered and governed and that piece, but that's a separate piece of analysis. I don't know if that
Okay, that's what my assumption was, but I just was not sure if knowing governance, right now at this time will impact all the analysis that you have already done or are planning to do. But you've answered my question, so thank you.
I was going to say, other commissioners, if there's different thoughts on this.
Yeah. So first of all, to me, governance and broad system design are two separate questions, right? Broad system design is, let's go back to the Universal Healthcare Work Group, right? Broad system design is, are you going to do Model A or Model B or Model C? And then governance is, how are you going to oversee whatever the system is? And I know this looks weird, but I have a issue. But anyway, so that's the only way I can say it. So I think what I'm just having a hard time distinguishing between what people want us to do first. I agree definitely that making a decision between Model A, Model B, and Model C definitely impacts financing. If it's Model A, you're doing fee-for-service rate setting, or you're setting capitation fees. If it's Model B, you're giving some discretion to the managed care plans, unless you decide that you also want to be telling the managed care plans how much they're going to be paying providers. And the question of who sits on the entity that governs, there, I think the really big question is it consumers and purchasers? It's sort of like the healthcare cost transparency board, right? There was a conscious decision made by the legislature to say that the board would be purchasers and consumers and not providers and insurers. So I'm sort of like, I think to me, dealing with governance is having a discussion about system design. And I do think that could precede a discussion about finance.
Others?
Could I ask a quick question? Ross Valori, Director of Board and Commissions here at HCA. Have we put forward any type of definition when we're talking about governance? Just hearing a lot of different perhaps interpretations of what governance is, and wondering if having a definition or a shared definition to help our understanding would be useful, or if we've gotten to that point yet of trying to define what we mean by governance.
Just kind of going back 3 years ago now in that the inaugural report, we talked about each section, but we haven't gone back and looked at it again in a while. So that's a really good point, and we could bring it back for another meeting to talk about it. I hear I hear Jane's comment too about, and I heard you say this as well, Badisha, that we could move it up after these three pieces around that you've all been kind of going at with the benefits and the cost containment reimbursement. Because one of the things you said, Jane, about you could decide how you want to pay the providers, and one of the questions that we have for today is related to reimbursement. You want to know more about different ways to reimburse providers, and if you want to be very directive, it could be carried out in a number of different ways. But could that conversation about system happen right after all those pieces? I think the approach that we were taking was more of, let's kind of map out the specs with the commission and then see how much different administrative things, how it could be played out and how much it would cost.
And financing what's in the scope of the finance?
The way that we've been thinking about it, and others please chime in here, is that the first three pieces that we've been talking about, four pieces, the eligibility, the benefits and services, the reimbursement, and the cost containment, that will tell us how much the system would cost, potentially, the benefits and all those pieces. The financing would be, and depending on how much you all want to be directive about cost containment or how you want to reimburse providers, however, the specifics you want to get into, that could affect the overall cost of that set of things, the benefits, cost containment, reimbursement, and the people that we're covering. However, the second part of that is depending on those decisions, it tells you how much you need to finance, like how much we need to tax. That financing, and the way we've been thinking about it, is how much money needs to be raised in order to support the system. So that's why we've been focusing on these other pieces first, because those decisions will drive how much money needs to be financed.
I think sometimes I just think of things differently because I come from the Indian health delivery system. It really is a universal health system. It's a system of care. And to me, it's having governance versus kind of top down. And I think we're doing like, bottom up, building the foundation. And then to me, I can't understand how we would figure out the governance until we knew all the pieces. I think these other things are important, I guess.
Are there other commissioners? Oh, Mohammed.
Nicole says she's having trouble hearing. Sorry, Nicole. I'll use my longhouse voice.
Yeah, thank you. It was a bit low for me too. No, I was gonna say, I see this playing out in so many different ways, but I think, at least from as far as the public is concerned, the trust is what we're trying to build is something that is different than what we have, that is quite failing everybody. Now, there has to be a transparency in that process, and who basically the governance, at least answering that question right now, might give people and even legislators what that look like, if in terms of access, in terms of how flexible it is, how, like, if for example, if we build a system that is not designed to incorporate feedback from the public, how useful it's being to the people, and if it's not flexible enough to be able to change to the to the public's demands, then we might as well be spending all this time building something that's similar or even worse than what we have. So I see it from that perspective, but I can also maybe suggest or recommend that we continue this conversation. Maybe we incorporate in our next meeting to have an expert actually come and do an actual analysis or what that will look like. If this would make us design or help the state move towards a better solution to the systems that's failing already, or if this is just gonna, burden the process and maybe make it longer. I just wanted to add those few.
Any other comments? So it sounds like I heard a couple folks, I heard Badisha and I heard Jane say that that there may be a possibility that it might be a good idea to think about moving it up after this set of activities that we're going on right now. But sounds like folks want to have a little bit more of a discussion about what do we mean when we're talking about governance before we make that decision.
And does it help to think about how the exchange was developed? Because that's a public-private partnership. The work started with the healthcare authority.
Then it moved out. That's a good idea.
History of that for the next meeting. That helpful. You guys probably know it. But I don't think all
Or
of
if there's, if there's other examples that we can bring forward to think about. So if folks didn't hear, I'll be allowed to. Vicki just suggested that we might want to hear about how the exchange was set up. It was started and having more details about that, or have some other examples for a conversation.
And to me, that is governance, right? There was a decision made to have a board independent, quasi-public entity, board members nominated by legislators to ensure that it was outside, at least partially outside of state government, with clear authority defined in large part by the Affordable Care Act, right? Because they had their marching plan that they were implementing. To me, that's governance, right? The issue of are you going to use managed care plans is not governance. It's sort of overall system design. And that's why I've been thrown off by this kind of discussion.
And I think, I mean, others chime in here. I think that's how the staff and we were thinking about it in that similar way. And for that piece of the governance, that's why it came at the end, because it was sort of like let the form follow the function. But I think that what I've heard the commenters say, and I think you were saying this too as well, Jane, is that the decision about how it's administered, I guess, or the system itself, yeah, there are implications for cost potentially there. And I think the question that we've been sort of going on around about is, as we'll see in the conversation that David's going to lead later, when we make enough decisions about how we're going to reimburse providers or cost containment and who's covered and those pieces right there, is that enough to then kind of model out or put it out for different people to say, I could do it for this much, or this will cost this much to administer it that way? I guess that's where I'm like, so I think that comes back to maybe we can have that conversation next time and really distinguishing between those two pieces, as you said.
So if I'm hearing you correctly, given that these are the benefits we want to cover, here are the cost containment mechanisms we want to integrate, and here's how we want to pay provider. What model does that, what system design does that lend itself to? Or that, and then because that, if that drives that discussion.
It could. I mean, it's kind of, I thought of when we were talking about this, I thought it's almost like the specs on the house. And then you look at different ways it could be built.
This is Ross Moore, HCA staff. No, sorry. Would it be helpful if HCA staff brought some definitions of governance to the next meeting for consideration for the group, or some other way of, I know we had talked, if someone had mentioned an expert on governance, but perhaps another approach would be bringing some other definitions to help focus our discussion and figure out which definition suits the work that we're doing.
Or maybe examples rather than definition, like the exchange, a trust.
Sure, yeah. So examples of ways that specifically Washington entities are understanding what governance means and how it looks within their organization.
I think we can also, we could ask our peers in Oregon, like when they're talking about governance, what does it mean for them? One of our colleagues is supporting some of that work. So we can bring some examples forward, and have staff share.
We're really behind on the schedule.
Yeah, sorry. Okay. So I at this point, it sounds like there's openness to considering it, to moving it up, but we need more information on some of these things. So just want to make sure that's how the commission you're in agreement about that.
Does anybody have any reservations about that plan? Charles, sorry.
Yeah, no, I don't have any reservations. So just been thinking through the different ideas that have been shared, and I'm looking at the milestone tracker and wondering, given this opportunity to rethink how we progress in terms of the sequence of the deliverables, if would it it would be helpful to look at the goals, right, of what makes sense for the commission to try to define upfront versus what could be, because some of this I would imagine will have to be dynamic, right? We can only anticipate so much with regards to how the market and things will evolve to try to be too prescriptive about exactly how the system will run. As against an alternative could be conceptualizing, okay, who will actually administer this, or the sort of what we're talking about in terms of the governance and what would that look like? What are the big aspirations with regards to how do you achieve? First of all, it has to be right. So that's what we're talking about, financing and costs. It has to be economically feasible for this to work. So perhaps another way to look at this is to look at those big picture things in terms of governance, in terms of how do we fund this, and is it feasible? And then I wonder if, and then maybe some broad goals around what will be covered. So, but I wonder how much important it would then become to get too prescriptive on these are the cost containment mechanisms you have to follow, or this is how you will reimburse providers. I wonder if that is maybe more for a later work for the actual commission, state agency, or whatever entity we entrust this responsibility with. I wonder if that becomes more important later on, when this is actually adopted and established, for them to continue to work on how do they make sure that they put in place cost-cutting mechanisms, as against spending more time up front on those fine details, without first asking the questions about what is the benefits and how feasible is this going to be and who's going to run it, and then letting them have that flexibility to continue to tweak how they run the system to make it economically feasible. Just thinking out loud. I'd see that, if that helps us rethink how we're approaching this.
I think that's a really good comment, and illustrates kind of the flip of doing it a different way. So we will talk about that at our next meeting in June, right? Yes. Okay. Thank you.
Oh, sorry, Mohammed.
I'm so sorry for coming back to it again. I think the public comment that connected the question of governance to the discussion of FTAC came from Riley Watts. If that person is still on the call, or is it can we ask for more clarification if instead of waiting until the next meeting, or maybe that might save us some time? And I was also interested in what the FTAC committee thought about this particular topic. So I don't know what that would mean structurally or to the rules of the commission, but may I suggest if we can have Riley maybe clarify that part for us?
Does he have access to the chat if he's not a panelist?
still
We are also behind. We are really behind, so maybe Mr. Watts could put that in an email to
Yes, that'd be
commission.
great. Yeah, Raleigh, I think you have the general HCA. In fact, I will send you an email from that address so you have it, but the general Healthcare Commission inbox.
I'm sorry, I'm gonna move us on, but please, if there are people who have comments, you know how to send us your comments, I believe. So thank you to Mary and Liz and the commission members for that discussion. Now we are going to turn to David DiGiuseppe, who is the FTAC liaison to the commission, and David has more than one topic to cover today. We will start with an update from the March FTAC, then move to the results of the recent cost analysis. And it's a lot of information, and there will be more than one opportunities for questions with David as he is presenting. And thank you, David, for joining us today.
Oh, you're welcome. Thank you for having me. It's great to be here. Can you confirm that you can hear me okay?
I can hear you fine.
Okay. And Mary, can you tell me, is Peter on the line as well?
Yep, Peter's here.
Okay, great. Thank you. So folks, Peter Hallam is the expert consultant from Milliman who prepared the study that I'm going to talk about, and will be here to help answer questions. So if you could please advance to the next slide. We had our most recent FTAC meeting on March 13th. There were three main topics that I'm going to report out on today: the public comment, the benefit cost analysis that we've just been discussing, and then the cost containment memo and how that fits in to all of this. We will then transition to a suggested framework from my colleagues at FTAC to the commission to help channel and focus the remainder of the work through the first half of 2025. Next slide, please. So starting with the wrap up of last month's meeting, you could go to the next slide, please. We opened with public comment the same way that you do. We heard many of the same types of themes that were voiced today: advocacy for a universal system, and a request that we look to other studies internationally as models to guide our work. Advocacy for the Washington Health Trust proposal, and a request for a fiscal note or a funding study. There was also the question about administrative expense, which we heard about and talked a lot about moments ago. And then, of course, advocacy for the governance structure, which you are all now engaging in that discussion. Next slide, please. All right, the bulk of our meeting was spent on the benefit cost analysis. There are some important caveats that we want to start with. What has been studied thus far is what we're calling a sizing exercise. So there are no recommendations at this time, no endorsements from FTAC or from the commission, from HCA or Milliman around chosen or selected benefit design for a universal system, funding sources, or any other component of the system. So what we did do, or what Milliman did do at our request, was to start with the spending in the system today on healthcare services. And when we say as of today, it was actually 2023, which is the most recent year of complete and reliable data. So the results that Milliman ran were not trended forward to 2025 expenses. And we looked at a number of scenarios across benefit designs and eligibility subpopulations. I will say too that there are 9 seats for FTAC, and 3 of us volunteered to be what we call the FTAC liaisons to the Milliman HCA benefit cost analysis. I believe we started working with Milliman in November of last year, meeting frequently to design the study, and then right alongside as Milliman was conducting the study, coming up with interim questions and assumptions to clarify those assumptions. And then we were able to react to the results and help shape the discussion for the full FTAC meeting. FTAC had about an hour, hour and a half to review the analysis, which is extremely complicated, which you'll get a taste of that here. There's a 60-page report that Milliman has written. And what we're trying to do today, we felt it was our job as the finance and technical experts to try and summarize the results that have broad policy implications for all of you. So what you're going to hear today is a fairly high level of the results. But as I go through, if you have any questions about the underlying details, please feel free to ask. Next slide, please. Okay, so what was completed is what we're now calling round one, because we are suggesting some additional rounds to the analysis. The second bullet here is a link to the full study if you want to see that. Milliman has delivered an addendum, which is some additional detail that breaks the results down by market segment. Next slide, please. Okay, so the starting place for the study was we had decided in concert with the commission that it isn't feasible to bring all populations in the state under a universal system design. So you've heard us talk about the state not having the ability to take control of Medicare without congressional action. And similarly, there being issues with the state taking control of ERISA-covered populations. So where we started was with folks who are currently covered by Medicaid, folks who are currently uninsured, folks who are covered by the state employee benefit programs, folks who are covered under the individual market, and then a few miscellaneous other coverages. So that represents about 3.4 million people in the state of Washington. Those people are covered by a variety of benefit designs, as I mentioned earlier, and as you can see on the right-hand side of this slide. So for example, some of those people are covered by Medicaid benefits, which has its own cost structure, its own provider reimbursement structure, and its own benefit and cost sharing structure. Other folks are covered by Cascade health plans on the exchange. Cascade Care is the name we give to the essential health benefits in the state of Washington. Depending upon your metal level, whether you're bronze, silver, or gold, you have different levels of cost sharing. So with that said, Milliman estimated that in 2023, the total cost of healthcare services for these 3.4 million people under their current coverage is $16.3 billion. That's going to be the benchmark that we're going to come back to as we go through the scenarios that were modeled. Next slide, please. So the first scenario took the assumption of if all of those people were moved into a Medicaid-like benefit design. So if every one of those 3.4 million people had Medicaid benefits and Medicaid cost sharing, which is zero. So if folks had no cost sharing, and then we added dental coverage in, the cost of healthcare services would increase from 16.3 billion to this range of 20.2 billion to 23.7 billion. There's a range here because there are numerous assumptions that go into the modeling. There are different provider reimbursement rates that can be modeled, for example. There are different drug pricing assumptions that can be modeled. And those are two examples of some of the bigger assumptions that went into the study. So the numbers that are circled on the right are simply the difference between 20.2 million and 16.3 million. So that's the 3.9, billion. That's the 3.9 billion that you see. The 7.4 billion is the difference between the 23.7 billion and the 16.3 billion. So what this is saying is if we were to bring everyone into a universal, unified system, and we were to standardize the benefits, we were to standardize provider reimbursement to be a blend of all of the different rates that are paid to providers today, if we weight those or normalize those together. And then we can vary the assumptions to say, well, what if we paid providers less than providers make today on a statewide normalized basis? What if we pay providers more than they make today. And that's part of what drives that 3.9 billion to 7.4 billion. So another way to think about this is the current estimate of moving all those populations together, eliminating cost sharing, the minimum cost increase would be $3.9 billion.
David, we got a couple of questions. Jane here.
Yes, yes.
So David, you were modeling for 3.4 million people.
Yes,
2 million of those people about are Medicaid, right?
yes.
I want to understand if this assumes a weighted average reimbursement, then given that Medicaid is more than half of the total number of people, the rates that we're talking about paying that would require 4 billion to 7.5 billion are closer to Medicaid than they are to commercial rates. Is that right? Just
You know, Jen,
of Medicaid being such a big chunk of the people.
yeah, so Peter, I'm asking you to listen carefully and step in if I state this incorrectly. So when Milliman looks at the system today, that's 16.3 billion, and they try to normalize that to a Medicare reimbursement schedule. You pull all this together and it comes out to be about 125% of Medicare. Since Medicaid is such a huge component of that 3.4 million, Medicaid by itself is a predominant driver of that 125% of Medicare average.
Okay, so
Which
it's like you're doing reference-based pricing to Medicare.
Yes, yes.
Okay. So the commercial is above 125% of Medicare, but not always, not for behavioral health, I know. Medicaid is often below 125% of Medicare, so it's sort of where you come out when you weight the populations and the lives.
Yes, and oh, sorry, go ahead, Jane.
What were the assumptions about the rates for folks who are uninsured?
So, Peter, I'm going to ask you to step in on that one.
Sure. Yeah, that was difficult to develop. And so as we talk about in the report, there's a lot of variability in our estimate there. We used information from a variety of different sources. I think one of the primary ones was some work that KFF had reported on, showing the amount of care that is compensated for Medicaid, or excuse me, for uninsured folks, and then estimated what percent of Medicare that would be, including backing out payments made by the Medicaid program for covering services for uninsured individuals, so that those payments were not double counted, since they're also baked into the Medicaid rates that we included in our analysis. So I cannot remember offhand what those uninsured percent of Medicare rates were, but they were lower than the other populations essentially across the board. That help?
Yep, thanks.
Vidisha?
Yeah, so in any of the scenarios, did you see decreased utilization and expense? Because I understand that the increased utilization is due to the elimination of cost sharing. But for, say, if you move PEB and SEB into a similar situation as Medicaid, so they're seeing reduced reimbursement rate, would they still have an increased utilization? So the elimination of cost sharing is more important than the reimbursement rate.
So, Peter, I'll take a stab at that. So that's a great question, Vidisha. I think I wouldn't describe a reduction in payment rates, because let's just say, I don't remember what the numbers were, Peter, but let's just say that in the study, PEB and SEB the average reimbursement rate was well above 125% of Medicare. So technically speaking, if a PEB member under this universal design went to a provider, the provider would receive a lower reimbursement rate. But because the provider is receiving higher reimbursement for folks who are on Medicaid or who are uninsured, the provider is, there's no impact to the provider in terms of overall reimbursement to the provider. So we're not modeling a potential change in access for a PEB member because the provider is experiencing a different payment rate specifically for that visit, because on the whole, the average provider in the state is receiving net neutral payments compared to the baseline.
Well, I mean, I know we are calling this universal, but in reality, the market, even if we, in scenario one, there are 3 types of patients. One that has this, like Medicaid like coverage. We still have the Medicare individuals, and we still have those who have commercial. So for a provider, they actually can choose between like how to spend their time. Would they rather spend their time with the Medicaid like patient? I know it's going to be a much bigger number, so double the size. But they can also choose from the Medicare, which will now have, higher reimbursement rate. And then there's the commercial, which is even higher. So will we see increased utilization from, everybody now in scenario one who is receiving the Medicaid? Like, I can understand that those who were previously uninsured, there will be some efficient moral hazard, but I don't know if that's true for everybody.
Yeah, I think that's an excellent point. I think what you're saying is, compared to the populations that aren't considered in this study,
right,
will there be physician decision-making about who they want to fill their appointment slots with? Peter, I would say we did not contemplate that dynamic for this particular study. Is that correct?
Yeah, that's correct. There were a number of externalities like that we held aside in our study. So I don't know if you had an opportunity to look at it, but towards the end of the report, we talked about some possible externalities, particularly related to reimbursement rate changes. I'm not sure we mentioned that specific one, but certainly we talk about effects on other health plans that remain in the commercial market, for example.
Okay, thank you.
Mary, are there other hands up?
I don't see any hands.
Okay, let's go to the next slide. So here you see the difference from baseline is lower magnitude than the previous slide. So this is scenario 2, where the assumption was to move everyone except for those who qualify for Medicaid to a PEB UMP classic design. So you see the term actuarial value on here, 13% of actuarial value. So what that's saying is, of the total cost of healthcare services at 100%, the patient would bear 13% of that in cost sharing of some form, whether that's a deductible, co-insurance, or co-payments. That's the estimated actuarial value today of the PEB UMP design. So naturally, the difference from baseline is going to be lower here because this is excluding the patient's portion of the cost sharing. Peter, anything you want to say about this that requires clarification relative to what I said?
No, thanks.
Okay. All right, I'm going to go on to the next slide. So the third scenario that we modeled was to move everyone except for those folks who qualify for Medicaid to a Cascade Care Silver design, and the actuarial value of patient cost or patient cost sharing, whether that's deductible, co-insurance, or co-payment, is much higher. So you can see that's 32%. So that's why the cost impact here straddles the baseline benefit design. It could be $1.1 billion lower than the baseline, up to $1.8 billion more than the baseline. And that's because on average, the folks who are now under this Cascade Care Silver coverage have worse benefits than the baseline scenario. That is, they primarily have higher cost sharing.
Any questions about that?
One addition to David's comment is, and I know that you said this earlier on, David, but the Medicaid individuals were held constant at a Medicaid-like cost sharing structure. So this cost sharing structure that's being described in his table here, as it says, is for non-Medicaid eligible individuals only.
Yeah, so just to recap, it's quite expensive relative to the baseline to move everybody into a unified Medicaid benefit with 0% actuarial value of their cost sharing. It's less expensive, but still more expensive than baseline to provide everyone beyond those who qualify for Medicaid with a PEB/CEB design. And then it's essentially cost neutral to the current system to give everyone the Cascade Care Silver design. And the reason why we have these ranges, the minimum and the maximum, are because we're varying different assumptions within a given scenario, including provider reimbursement rates and other assumptions. Okay, let's move to the next slide, please. Are there any additional questions before I get into what we at FTAC came up with as a framework for what to do with this information, how to move forward on those 4 key components that Liz and Mary identified earlier?
So David, just quick, if I remember the
Yes.
context of the report, or the latter part of the report, you also did some modeling where you pulled in the fully insured small and large group folks, right?
Yes, that's right.
Just about another, based upon current enrollment, it's about another 900,000 people. And because technically, right, the state could include those populations in fully insured health plans. So how much did pulling those populations in change these numbers? Just curious, and I can't remember.
Yes, that's a great question, Jen. I think I have a slide on that, unless, Peter, do you remember off the top of your head the answer to Jane's question?
Not exactly on the numbers, but what I will say is the overall results came in around the same. So it was more expensive on the same order of magnitude to have the first couple of benefit scenarios, and within the range of our estimates, cost neutral under the third scenario. So similar overall results, but I don't have the numbers on the top of my head right now.
Jane, if you don't mind waiting to that slide, I think we might be able to answer it more specifically on that slide, and you can stop me there if I don't answer it.
Yep, that's fine.
Okay.
We have a hand up, David. Charles's hand is up.
Yeah, thank you. So a question I have is regards to the what we are living out of the model currently, right? I recognize the limitations we are facing with regards to currently not having a policy lever to be able to include the Medicare and ERISA covered lives. But I believe a big part of the challenge with our system today is the problem of underinsurance, right? The people who are actually insured, but still face significant financial barriers to accessing care and who are making decisions to not receive care or to follow up with care because of concerns about their out-of-pocket costs. So I will imagine that if we're truly envisaging a universal system, and by universal, we're really saying a system that actually addresses those financial barriers, that perhaps one way that we could get around the problem of not having control over federal policy could be a supplemental insurance, right, that essentially picks up what currently the federal ERISA or Medicare doesn't, for example, dental for people on Medicare, for example, right? So is there a way that we do a model that actually is truly universal, where we're not just focused on the populations for which we have ready policy resources to address in this phase? Because if the goal is a system that works for everyone, I think Washington, for example, is very much ahead in terms of having a less proportion of uninsured. So it feels like the current model focuses more heavily on those who are not already covered, or maybe the third and said which the state has a bit more control. So I'm wondering, how do we make the model a bit more inclusive that actually addresses the problem of underinsurance? Because I think that is the US is having a bit of global perspective of seeing how things run in other countries. I believe in the US is one of the few countries where people are actually scared to use the healthcare system, because it's not just the experience of going to the doctor, it's the fear of what's going to come in the mail in terms of the bill that will come in the mail after you've used the healthcare system. So that actually discourages a lot of people who are insured from actually engaging with care or following medical advice, because they're afraid of the bills that will come in the mail afterwards. So I'm wondering how a model actually addresses that problem of underinsurance, and if that's something that's already I know it's incorporated in some sense by you looking at how do you apply the Medicaid type of coverage for those on SEB and all that, but how do we make this a bit more encompassing?
Yeah, Charles, I think that's an excellent observation and point. And maybe I could give you a two-part answer, and then I'll invite Peter as well. I think what you said at the end is one assessment of what that might look like. So, underinsurance referring to people who have coverage, but they can't afford to use it because of their deductible, because of their cost sharing, co-insurance, co-payments, et cetera. So as we look at modeling those richer benefits, the PEB and SEB benefit compared to the Cascade Care Silver benefit, or the Medicaid benefit compared to the PEB and SEB, Milliman is building in induced utilization. So more people utilizing healthcare because they're no longer afraid to be hit with the high cost sharing. And you can see in the results that there's a cost that goes along with that. In an upcoming slide, we do address the point of supplemental coverage, or the idea of needing to study supplemental coverage as a second round of the study. So I think that may get at your point, but you can tell me if that answer doesn't address your points.
Thank you.
Okay. Peter, do you want to add anything to help answer Charles' question?
No, thanks.
Okay.
Mohammed's hand is up.
Yes, thank you. Just to Charles, to add on, I remember, especially from not only from the work group that preceded the commission, but also in the early discussions, one of the lenses that we want to use is to improve access, which, if giving someone an insurance that they cannot afford does not improve access. What lens? Just the question is, what lens what lens is that set the parameters you're using is considering a lot of the values that we set in the beginning of the commission, if I might ask that.
Okay, so Mohammed, I just want to make sure I understand your question. Are you asking if we started with some guiding principles in order to design the study?
Yeah.
So I'm trying to think of the best way to answer this, and Peter, I'll ask you to chime in as well. Where we started was in order to help the commission think about the benefits and services question and provider reimbursement question, so forth, how do we outline these scenarios so that we can make some meaningful comparisons in, what's the dollar impact of making those changes? I don't think we're at a point where we would say the scenarios need to be guided by a set of principles. I think those are going to come later as we think about, okay, what options would the commission then want to put on a list of reasonable options for the legislature to consider because of impacts on things like access and so forth. Peter, would you say anything differently than what I just said?
No, I think you said that well. Our focus was to price out some spectrum of designs without a focus on desired policy outcomes.
Okay. Mohammed, does that satisfactorily answer your question?
Thank you. It does. Thank you.
Okay. Okay, Mary, I can't see any.
I don't see any more hands.
Okay. All right, can we go to the next slide, please? Okay, so what we're trying to do in this next section is to help you as commissioners think about, well, what do you do with this information? And there are multiple directions that you could go. This is a framework that we came up with that we thought would be helpful to narrow down and focus the questions that you'll ultimately be wrestling with and potentially directing FTAC to do further analysis on. So this may or may not resonate with you, and I invite you to provide negative or positive reactions depending on how you feel about this. So if we could go to the next slide, please. So a few caveats here. We're using the results from the Milliman HCA study in order to present this framework to you. This is extremely complicated. The analysis was extremely complicated with a lot of assumptions, a lot of moving parts. So just consider this directional and subject to change. Next slide, please. So I'm going to focus on the top four ovals on the left: eligibility, benefits and services, cost containment, and provider reimbursement. Next slide, please. We do have some guiding principles, coincidentally, for this framework. So what one of the key things that you'll see is these milestones are interdependent, and I'll show you an example of that. Our understanding at FTAC is that the commission is working toward assessing financing options in early 2026, and that ultimately you'll need to develop a set of options and costs of options that you're going to present as the commission's recommendations to the legislature. Next slide, please. So here's an example of the interdependencies. So if you start with the benefits and services box or oval there, you saw in the analysis that there is a significant impact on cost the richer the benefits are. So that ultimately triggers a financing issue. And to the extent that additional financing is a necessary component of a new universal design, that increases the importance of cost containment mechanisms. So that's one example of a feedback loop or the interdependencies amongst these 4 or 5, well, I guess all of the boxes on this page. Next slide, please. Okay, so at a high level, we're recommending that 2 additional rounds of analyses could be done. There could be further exploration of a selected benefit package, depending upon whether you as a commissioners feel we need to model anything beyond what has been modeled so far. There is this question of creating opt-in benefits for an expanded eligibility pool, similar to Mohammed's point about supplemental coverage. And one of the things that we talked about at FTAC is the desire to actually project costs to a future year. Just to reiterate, what we've done so far is calendar year 2023. If there is going to be a legislative request for additional funding, we will likely need to project that dollar amount into the future. And then so far what we've talked about is having a third round of analysis that brings in the infrastructure and the administrative cost component that was discussed earlier in today's meeting. Next slide, please. Okay, so essentially what I said earlier, just looking to see if this framework is helpful, if we're on the right track, if this is giving what you all need for your decision making. You know, we understand at FTAC that this is extremely complicated and a lot of information to digest. So hopefully this gives you an idea of, or something to anchor to as you're thinking through these questions. Let's go ahead and go to the next slide. Once I get through this, we have time. Liz is going to facilitate a discussion on these items. So just focusing on the benefits and services, these I think are the questions that would be helpful for FTAC to hear your responses to. So you saw that we modeled 3 different benefit scenarios: the Medicaid benefits and cost sharing versus PEB and SEB in our scenario 2 versus Washington's Cascade Care Select, or sorry, Cascade Care Silver. Another question is, so sorry, that first bullet is the services to be covered, and there are differences in service coverage between those 3 benefit packages. The second is the cost sharing. And the third bullet is asking if there should be a standardized benefit for all beneficiaries, so all 3.4 million people, or as we modeled in these scenarios, would Medicaid beneficiaries continue to have Medicaid benefits even if the remainder of the 3.4 million people had a different benefit design? So the blue box is just trying to get to helping formulate your direction back to FTAC. So we'd like to know, are there any additional benefit options, service coverage, cost sharing that you'd like us to model such that we can then go into a second round analysis? And the later bullets there are talking about what I mentioned before of we think it'd be wise to try and project these forward as the basis for future financing, if that's something that you agree with. Mary, I think I'll just buzz through these fast and then Liz can facilitate questions then, or are you seeing hands right now?
No hands right now. I think that's a good plan.
Okay, if we go to the next slide, please. On the eligibility front, Jane, this goes back to the question that you were asking. So if we bring in that ERISA fully insured population into the baseline scenario, so if we say we're going to expand that circle, that takes our baseline from 16.3 billion to 20 billion. So that's basically saying there's 4 billion of expense for that ERISA fully insured population. And then if we go through those different scenarios and we fluctuate our assumptions, the cost could range from a decrease of 1.3 billion to an increase of 11 billion relative to that $20 billion benchmark. So as that sinks in, you can let me know if that doesn't answer your question.
It does, thanks.
Okay. So here we think the outstanding questions for the commission are, do we want not only the ERISA fully insured population included, but there are some other populations that I think were mentioned at the February commission meeting. VA beneficiaries, for example, who may not be taking advantage of the VA system. There was also the question of wraparound benefits for folks who have a delivery system like the VA folks who are covered by the Indian Health Service. Would it be possible to create and model what a wraparound set of benefits would look like for those people? So to the extent that the commission would like FTAC to address these populations who could have some supplemental coverage, that's something we'd be happy to incorporate in a round 2 analysis. Next slide, please. Provider reimbursement we talked about. So as I was describing in response to Jane's question earlier, when Milliman normalizes the current payment rates across the 3.4 million people, that's where we get 125% of Medicare fee-for-service. So in Milliman's sensitivity analyses, they varied that by plus and minus 6 percentage points. So if the overall level of reimbursement was decreased to 119% of Medicare, that would reduce all of those scenarios by about $1 billion. Likewise, if reimbursement rates were increased by 6 percentage points to 131% of Medicare, that would add an additional $1 billion to the various scenarios that we modeled. The last option there you see was 160% of Medicare fee-for-service, which is the benchmark that's used for Cascade Select as the affordability standard currently in the state of Washington. If reimbursement rates were increased from 125% to 160%, that would add $4 to $5 billion of total expense to the system. So that turns us back to questions for the commission. Are there additional payment levels that you would want us to model? And what the second bullet says there is, are there any differential payment structures, for example, increasing payment rates for primary care, but holding payment rates, normalized payment rates level for non-primary care services? And I think Badisha's question fits in nicely here too, about thinking about those externalities that we talked about. Next slide, please. All right, so then we get into the questions of infrastructure that we talked about, thinking back to Model A and Model B, and what's the best way to administer this? What would be the administrative cost associated with that? Model B is essentially similar to what happens today in terms of coverage being provided through health plans. If we were to move to Model A, would that generate savings in administrative expense relative to what's in the system today? And of course, that would require some additional analysis. Next slide, please. Then that takes us to financing. One of the questions around financing is the dynamic of shifting cost responsibility across payers. So you can imagine if we were to normalize and create a reference-based fee schedule that was common across a single value across all markets, commercial payment rates would go down. So the folks who finance commercial insurance today would be paying less, and Medicaid rates would rise, for example, and so the state would be paying more money. And so you'd have this cost shifting that would have to be addressed to understand, well, who's bearing the burden of that overall cost. And what we're saying here is that FTAC would need to study this further and bring in peers from OFM and Department of Revenue and Legislative Finance Committee staff to help work through and talk through the options for you all to consider here. Next slide, please. Finally, cost containment, which we've talked a little bit about. The main point is for this meeting, so as you can see from the results of the benefit study, that where you all land on benefits and services and with provider reimbursement are going to be significant drivers of the cost structure. At the May FTAC meeting, we're going to get into reviewing an inventory of cost containment strategies that we've pulled from previous work that OIC and the Attorney General's office published last year, current practices in the system today, and then other practices based on ideas that folks at FTAC are familiar with. So we're going to deliberate on those at the May meeting and prepare recommendations for you that we would deliver to the June meeting, to your commission meeting in June. Okay, that felt like a lot of information in a short period of time. So I think that's the last slide. Is that right, Mary?
I think so.
Okay, thank you all very much.
Thank you, David. Thanks, commission members. Time for a short break. We have a 10-minute break scheduled, but we're really behind. Can we push it back? Good job,
You
David.
caught us up.
Caught us up almost. Can we take a 5-minute
good.
break? We want the full 10-minute break. 5's fine. Jane says 5's fine. Buck up,
Dave
guys.
agrees.
Dave agrees.
Okay.
Right. See you in 5 minutes at 3:52.
Yeah, we're good.
Are we all back?
We are, I think so.
Okay.
Ready to launch the beach.
So we're on tab 5 and this.
On tab 5, yes.
She's gonna go back and talk about the question.
Yes, we're gonna try to go back and go to all the questions. I think it was a lot to digest, and I just want to kind of recapture or just recap what we heard from David. At the beginning, you talked about 3 rounds of analysis. One is the one that was just completed, which focused on looking at different benefit service packages, including a PEB/SEB package, Silver Plan package, and Medicaid package for the populations that we have decided we can definitely cover without federal permissions right now. You also talked about a second round of analysis that would factor in pieces around doing an opt-in for the folks that are not covered, that were not part of that population initially, like folks like on the VA, people in Medicare, an opportunity for them to sort of buy into it or be wrapped. And also adding information about cost containment and reimbursement. And then there was a round 3 proposed in addition related to the infrastructure things. So we had those 3 different rounds. 1 has been completed, and now we're going to talk about refinements to the first one and thoughts on phase 2, on round 2. So I think just going back to the round 1 and what we heard from David and the Milliman, Peter at Milliman, there were 3 scenarios. And can we go back to the slide that has the 3 scenarios? They're not numbered, so
Yeah.
Okay, so keep going.
I think it's at the very beginning.
It's at the very
Audrey.
beginning. And
Oh, go back one. Just had it.
And really, the question that we have, for the commission, our first starting question, which of these 3 scenarios, in terms of the benefit package, it seems to resonate with you, or seems to make sense, or something you're concerned about, or something that jumps out at you? We saw that the Medicaid providing Medicaid for everybody would be a significant expense. We saw that providing the PEB/SEB would be a little less, but than the Medicaid, and that providing the Silver Plan through the exchange would be the least expensive option. But there are trade-offs for some of those, and so just wanted to get a sense from commissioners. What are your thoughts on those 3 different scenarios? Any reactions? Some people would be gaining some coverage. Some people might be losing some coverage from what they currently have. And what are your all's reactions to that?
Happy to kick us off. So I'll start with a little bit of a reaction to scenario 3. And that is a scenario, only in healthcare and in legislative worlds can you say plus or minus 1 billion is cost neutral. And I've been there and I've said that myself, probably even this session. And at the same time, that scenario, to me, the value of having that scenario is to show what a cost neutral scenario buys. That scenario being the one where the cost shares for everyone that's not Medicaid are adjusted to about 32% actuarial value. That, I think, represents a significant loss from status quo for, I can speak quite frankly, for at least for PEB and SEB, but I think a lot of people would go, I think that's one to compare to and probably not one to recommend. I think it is something that's worth continuing to evaluate to show what a cost neutral option is, because a lot of times when modeling is done, that if you don't include that as a model, everyone goes, well, what is today's dollars buys? And so I don't think it's one to aspire to or to particularly propose, but I think it is one that needs to be part of the analysis to show what is the cost neutral option. Again, core concept probably the average person that plus or minus $1 billion is neutral. But I think that there are a lot of very engaged stakeholders who would see that particular option very challenging. And I think that the average person who is looking and engaged in a universal conversation is probably not anticipating that there's something that still comes with a 33% price tag of bills whenever they leave the hospital. And so I think that if that were the end result of the entire multi-decade conversation, I think there would still be a lot of people really unsatisfied with that outcome.
So that comment that Dr. Chima made about the underinsurance, this would be problematic for a lot of folks in access. I see Laura Kate's hand up.
Yeah, I'm happy to turn the microphone over.
Thanks. I agree with Dave. And I think that a general principle for this work, and for the commission as it starts to narrow in a little bit more on this should be, let's take an approach where we're not taking things away. Let's make sure that we're thinking about a runway that adds, and a 32% AV is really paid by the patient, is, as it says here, worse than the status quo for many. So I agree that it's helpful for illustrative purposes, but not something I think that the commission would aspire to. On the other side of that, I think a very aspirational goal is no cost sharing. So really this option one, and how does the commission think about a runway and a likely phased approach to getting there that also has this principle of let's not take away, let's think about a place where we're adding.
Any other comments on this scenario? Do you want to go to scenario one? Since you brought it up, Laura Kate, that's the Medicaid scenario. Okay.
So, and I'm going to be a pain in the neck because I wonder, and this brings in the cost containment discussion, because this is sort of assuming that the way we're structuring benefit design doesn't change radically, right? This is 13% of AV. If I'm hearing, David, what you and Peter were able to do with the funding that you had. And so a couple of things come to mind on this. If we were to say, we're going to pump up primary care and assume use of an advanced primary care model, given all the research that's out there that shows reduced hospitalization and reduced ED utilization, does let's say scenario one have to yield the cost that it's yielding if by virtue of plan design, you can change the incentives to reduce the use of really expensive services? Or do you do plan design that has much higher cost sharing for an ultrasound than a CT scan, right? To incentivize people to use the less intensive radiation, radiology treatment. And so I guess my question is, can we build in assumptions about plan design that can make scenario one not as expensive or make scenario two, like David said, look more like budget dust because it's only $1 billion? So, because I just feel like we're assuming status quo and we want to change the status quo.
Yeah, I think, I don't know, Peter and David, if you want to chime in, but the one slide, if we can go to the reimbursement slide, because I think it starts to get at that, Jane, that comment. On the reimbursement slide, which is one of the pieces that the FTAC wants your direction on. they modeled it with 125% of Medicare. And there are a couple options laid out here, 119% of Medicare, 160% of Medicare. However, I think to your point, Jane, there are some decisions about that could be different about paying for different sets of services, a different amount, like one of the things that's being discussed during the legislature right now. And do you want, and this group talked about it last time. We talked about this group supported the reference-based pricing legislation, I believe. Would you like to see Milliman in another round model something like that? Like, we want to pay for these kinds of things and pay less for these kinds of things. So
I'd also like to see if and Peter, I'd love your thoughts on this. In scenario one, where there's no cost sharing, you have just carved out a boatload of administrative expense from providers, right? Because they don't have to worry about billing patients. They don't have to worry about chasing patients. They don't have to send bills out to collection agencies and lose half of the value. And what's the value to the provider in terms of, yeah, I'm happy to take a lower reimbursement rate if I don't have to chase my patients to get their money. Can that kind of a thing be modeled?
I assume that's a question to me. Yeah, that can be modeled. It is not what we did model, as you noted. I think there's an Oregon report that is in some ways parallel to our own, where they did consider some of those savings. One thing I would note is that it is possible that some of those savings, not all of those that you mentioned, but some of those savings might be those you'd see, in year 2 or year 3. So
Yeah, I get that. Yep, totally.
Mohammed. Yes. And I want.
Yeah. Mohammed?
Yes, thank you. Thank you very much. And I just reading through this, I'm thinking, would it be helpful if we added some values or principles as a parameter while we ask for additional modeling? Because at the end of the day, if what we get in are these choices, and we will work on a report to send to legislators at the end. If I do not think we are doing the service to the people of Washington if we are not basing everything that we're gonna send up to legislators based on the values that we have carved out. I know now we can play with the numbers and what that will cost, but if the values that we have set would make these numbers irrelevant, then this whole work have to be repeated somehow. So I'm just putting it out there. Would it make David and Milliman's job easier if we set with some guidance principles that without which this models might not work, because we want to improve access, we want to reduce underinsurance, we want to cover everybody and give them something of quality that has transparency built into it, that is that their voices that values their voices, all of the things we've talked about. If we don't center that, I think we're losing something very important in the process.
Thanks, Mohammed. I think, and just a reminder, we did do principles on cost sharing. Perhaps that's what we need to do with these other factors, but go ahead.
I have a lot of thoughts.
Yeah.
But so I think, we're looking at the benefits, but part of what's really important to good patient care, and I think Jane mentioned this, is really that the care coordination, case management, patient navigator, whatever you want to call it, then that's the funding that for the Medicaid program goes to the managed care organization. And I think in the rest of the system doesn't really exist as much. But to me, that's, I think, the important part is for somebody to have like a medical home. So a place that they always go back to, and somebody who can help them coordinate their care and help them make decisions. I think That's a system we used to have, we don't really have anymore because there's not enough money and time. And so I'm wondering about I think it's called the primary care certification. It was like there are 3 levels of primary care. Where if you are just seeing patients, you get paid this much. Seeing patients, doing some kind of care coordination, care management, you get paid more, and if you're doing even more, you get paid. I don't know if that fits here, because it is kind of outside of medical services, but it is an important part of. I mean, if we're gonna change the system, we might as well make it a system of care instead of a system of insurance coverage.
Well, couldn't you build that into your assumptions?
I guess that's my question.
I think so. I wonder, Peter, did you hear Vicky's question? So she's asking about things like care coordination and what Jane was talking about with primary care homes or medical homes. Could you build into your assumptions, kind of a beefed up payment for primary care or something that would pay for those things and, thereby potentially saving money because people are actually having care coordination?
Yeah, that's something that we can model. Developing that assumption would be difficult, but not something. Yeah, that seems reasonable.
You familiar with health homes program?
They have tiers. Oregon has 3 tiers. I don't know how they do it here, but
Oregon has 3 tiers for their primary care payment. Health homes are different. They're more on the home and community services side.
Okay, so it sounds like there is some opportunity for perhaps modeling more emphasis on primary care, whether it's through how we pay providers or if it's, an increased rate for that.
If the legislature, assuming that Senate Bill 5083 passes, it's the legislature saying we want to take an opportunity to rebound. And we want to invest more in primary care. We want to invest more in outpatient behavioral health services. So if the legislature endorses that approach for PEB-CEB, it seems logical for us to build that into whatever modeling we're. So downward pressure on hospital rates, upward primary care behavioral health. I mean, at 125% of Medicaid, you're putting a boatload of downward pressure on hospital rates. But that's aggregate, but you don't want to sacrifice behavioral health and primary care. Right? So,
Well, and I think the assumption is that by rebalancing, as you said, by putting more into primary care and outpatient behavioral health, there won't be so much happening at the hospital anyway. That's the theory. And so are folks hearing what Jane's kind of laying down about the reimbursement? We should maybe, especially if the legislature passes that bill, to model that out in this system, putting more reimbursement in primary care and behavioral health and lowering reimbursement in some of the other service areas.
I like that actually.
Just to put a real quick fine point on, even though I saw Lara's hand go up before I started talking, the Senate Bill 5083 has numbers like 200% Medicare.
Yes.
So just to remind people of the conversation that's happening in the legislature on that bill right now and the numbers that are on this slide right here, just a relationship, just to remind people that kind of, and although I was going to say this in my update, we don't, Senate Bill 5083 is necessary to implement the budget, and it is assumed and has assumed savings built into both chambers budgets that passed off the floor already. So there's a high expectation that some form of that bill will be passing. So just in case people that, it didn't pass yesterday's cutoff, doesn't matter on that one.
I see Laura, Kate, and Nicole.
Makes sense to think about the downward pressure and also just sort of the redistribution, if you will, on sort of the healthcare side. I really appreciate the conversation about the opportunity here to really rethink transformation of the health system. And I think part of that equation too is to think about which you've already started doing, but think about the demand side a little bit as well. So regardless of which sort of like AV that we're looking at here or cost sharing, I think really thinking about value overall. We started to think about it on the provider payment side. You know, the more that we value primary care, for example, the more we pay. And we want to protect that. I think the same goes for benefit design and potentially thinking about, you know, quality, affordable provider access as well, and how there are some consumer decisions that are part of that too. So I think it's thinking about all of these different sort of moving parts, and I'm so appreciative. I think it was David that brought forward sort of these interdependencies. So really thinking through the logic model here of supply, demand, value-based reimbursement, all of these things that are really important in achieving those overarching goals that Mohammed really continues to point us to around access.
Holt?
I could not have said that better myself. So Laura took the words right out of my mouth.
Dr. Chima?
Yeah, just a quick point about, I know that dental was explicitly called out in the model, but I'm not sure if vision coverage is also being on the table for discussion. So maybe I guess seeking clarification on that, and if not, is that something that could be considered as well if we're already talking about comprehensive coverage?
Right. Did you say vision? Okay.
Yes.
I cannot remember the exact benefits that were covered in terms of vision in the modeling that we did, but Appendix D of our long form report will itemize them.
So it sounds like folks would like to see, so Dave's point that the options on the slide here for provider reimbursement are less than what's being talked about right now. But the idea of potentially modeling something after what that legislation talks about for these different scenarios that we have to see what the impact would be, looking at other ways to lean into primary care or care coordination, making sure that that is emphasized. I think David, is that helpful for you and Peter? I want to go to the other question about the other populations.
Yes, that's helpful. We can move on.
Okay, so one of the other questions was for the sort of next iteration of modeling was what to do about the folks that are, you know, in Medicare or plan or VA plans where we thought we can't really cover them right now without some type of federal permission. Do we offer them a wrap? And I can't remember what slide that's on. Is it this one? Okay. So want to just have a conversation with the commission about this. Is this something that you would like for FTAC to look at?
It seems that before that, we should make a decision about whether we want to do the fully insured small group and large group. Because that we can do. That just seems, because they weren't included in the initial modeling. So I appreciate, especially if we would think about like a self-funded group health plan opt-in, if you're going to do that, why not bring in the fully insured? Let's remember that at least about 300,000 Hep 7 enrollees are in the fully insured market.
Mohammed?
Yeah, sorry, I'm really having a hard time hearing Jane. can we do something about that?
Yeah, Mohammed, so the model does not include the small group and large group fully insured market, which is probably about another 700,000 or 800,000 people. And so I guess the question is, since we have the authority to do that, right? And Peter, you may end up making assumptions about people migrating out of the fully insured large group market and into self-funded as part of your modeling, right? Because employers can always do that. But I guess the question is, do we want to include that population in the modeling?
Mohammed, did you hear that this time?
I did. Thank you very much, Jane. And yeah.
Isn't that the goal, is to bring those people
Eventually,
over so we
yeah.
can have the larger risk pool too?
Any other commissioners with thoughts on this? So Jane is saying that before we go to doing the wrap for, folks in Medicare or VA beneficiaries, that we want to model out bringing in the small, you're gonna have to say it because I'm gonna screw it up.
You bring in the fully insured
Fully
small group
insured.
and large group.
Large markets. Laura
This is
Kate,
Laura Kate. I think it makes a lot of sense to bring that modeling in, especially recognizing that within that market, there are a lot of people who struggle with underinsurance, which I think also, Peter, may make it challenging to think about risk pool, like who would opt into this. But I think, we know that there are smallish groups out there that really struggle with finding affordable insurance, and this would fill a need.
Mohammed,
No, I just wanted to add my support to that point. Not only people struggling, finding coverage, but they are, like, for example, we have a small organization. I have to pay half my paycheck every payroll to cover my family, which is six members. I can afford it because my wife works, but there's a lot of people out there that do not have insurance just because of that. So it would make more sense to bring more relief to a greater number of Washingtonians.
great. Okay. Peter and David, do you have what you need on that one for FTAC?
I think Nicole's hand is up.
Oh, thank you.
Sorry, I agree. Just curious, if we could also take a look at what the risk pool for the remaining folks, so if they stay within their small or large group, that's also something to consider what their rates might go to. I know the idea is that everybody would participate, but what happens if they don't? I don't know if that makes sense.
Good. Clearly, for self-funded group health plans, there's a choice about whether to come in. I guess theoretically anybody could opt out of a universal system and just say, I'm going to pay cash. I'm going to bear the risk. And employers that are now fully insured in fully insured health plans could decide their way of opting out would essentially be shifting to a self-funded or a level funded health plan.
Got it. Thank you.
David?
Yeah, Liz, I just want to recap on the first three topics we talked about. So on benefits and services, I'm hearing, I guess the most concrete statement I heard was Laura Cates of aim for scenario 2 with a ramp to scenario 1 over time. And I didn't hear any request to model any new benefit designs that weren't already there, with the exception of your general comment, Jane, around is there room for additional variable cost sharing for things like ultrasounds versus CTs?
And then primary care and behavioral health, right?
On the reimbursement, yeah.
Yeah. So then on the reimbursement, I heard take into account the 200% of Medicaid, or sorry, 200% of Medicare cap for hospitals under PEB and SEB, reweight that into our normalized fee schedule, and then look at differential higher payments for primary care. Have I got that one right?
I would just refine that slightly to say, after a bill passes in about a week, use those numbers.
Use the numbers that are in the bill, David.
Okay.
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 Yeah.
And then on this one, I'm hearing hold off on these potential supplemental populations and focus on bringing the fully insured population in first and enhancing the modeling with that change.
That is what I heard. Okay.
Okay, got it.
And David,
is
if I
there-
can add, I would just add that on the benefit design side, you might have spoken to it a little bit, but it's wherever we're sort of incentivizing on the provider payment side, where we want to make sure that we're focusing on access payment value there, that we're thinking about it on the benefit design side. So on kind of like the demand side.
Okay, got it. Thank you.
I heard Charles as well. Were you gonna say something?
Yeah, sorry. No, I was wondering, is there a reason why we have to do it in phases? So the question of first addressing the fully insured before bringing in, say, Medicare or VA Life. So is there a reason why it has to be in phases? Could it not be part of the same alternative scenario modeling?
Need a federal waiver to bring in Medicare unless you're talking about a wrap.
Unless you're talking about the wrap, yeah. Was that
Yeah,
your question,
yeah.
Charles, or are you just asking why we can't model the wrap and bring in those other populations in?
Yeah, exactly. Yeah, I mean the wrap. But I mean, like, why does it have to? Is there a reason why it has to be in phases, or could that just be part of the next set of models to expect?
I mean, I'm looking at David and Peter. I don't think there's a reason why not. Just
Yeah, and to clarify, at this stage, we're not talking about Medicare. So these specific populations here, like the VA beneficiaries, out-of-state employees, federal employees, folks covered by the IHS system, those are the ones we're talking about looking at a wrap or supplemental coverage. And I think we could, I think the legislature may have to allocate money for additional Milliman study, but I don't see why we couldn't incorporate that in a second round.
Great. Anything else on these pieces? The last piece that you talked about, I think, well, there were two other pieces. There was the cost containment piece and just making sure that the commission, if you all have any questions or direction you'd like to give to FTAC, because they're going to be looking at cost containment strategies at the May FTAC meeting. If there's anything that you want them to sort of keep in mind. Right. We've heard some of the cost containment, I think at the last meeting or two meetings ago when I think Bob Murray started talking, and so they're going to get more details on this.
Yeah, I mean, one thing I would think about is in the guise of cost containment is reducing administrative burden for providers. Because that's another, right? How many different ways could we try to get providers to accept lower reimbursement if they don't have to get money from their patients, if there is one standardized system for prior authorization, if so.
If they don't need to keep fax machines around.
Right.
So did folks hear Jane's comment that cost containment, we definitely need to be talking about the relieving the provider burden of administration things, which we've talked about in this group before too.
To reinforce Jane's point, I think part of it is also trying to capture and quantify the value of that to help explain or justify or convince that a number lower than the percentage of specific provider hospitals today is okay, progress, acceptable, tolerable, agreeable. Open your thesaurus further. Similar words.
And then we did the last piece was, and if you want to go to the infrastructure slide, the potential round 3, which we talked about before. And we can come back to this after we have the governance discussion in June about future modeling of this piece. That sound okay to folks that will come back after we do this next round of things and have some discussion about governance?
Yeah, I mean, we all have to see how much the legislature appropriates.
Yeah. Okay.
And
And if I'm this is
oh, go
Laura,
ahead.
Kate, I would just add, this does feel like part of the administrative burden conversation. So I think it can wait, but I do think it's definitely interrelated.
Yeah, thank you, Laura. Ross Valori again. Just wanting to note this great discussion about additional analysis by Milliman, but just wanted to point out that we don't yet have the funding yet for all of these studies. So we are still awaiting the conference budget from the legislature. So just want to reiterate that this work that we've contemplated here is not guaranteed yet. So we'll need to follow the legislature and the ultimate budget, but just want to reiterate that point for folks.
Hand it back to you all. Yeah.
Yes. All right, thank you. Thanks, everybody. Thanks, Liz, for leading that conversation.
Thanks to David, he did a really good job.
Yeah, David and Peter, thank you for really the report, and David for just really making that conversation as simple as we could get it. So our last agenda item is the report out.
State agency report outs.
Here's the state agency report outs. And we realize that the ledge session isn't quite done yet, but looking for some updates from our agency. And apparently in alphabetical order. Sorry, Dr. Chima, you're always first. Do you have any updates from the Department of Health?
Sure, yeah, there are a few bills that that we're tracking, right, including SB 5568, that talks about updating and modernizing the Washington State Health Plan. So this, include OFM, working with DOH and other agencies. Really, so this is what is supposed to underpin the Certificate of Need program that guides the approval of new hospital beds in the state. So it's past the House floor and still alive. So this, I think it's overdue. It's been a while. The state health plan was updated. So that would direct the OFM to sort of provide the resources to get that accomplished. So that is definitely one that involves DOH that we're tracking closely. There's also other ones, and a lot of them involves HCA, but as of interest to public health, right, including E2 SHB 1686 talks about creating a state healthcare entity registry. So this is really defining what kind of healthcare facilities should be officially registered, so that we know where different kinds of facilities exist and what kind of facilities should be by law required to register and tracked by the state. So that is that I think that I suppose both houses, both the Senate and the House. And then there's also the governor has signed SB 5084 that talks about health career reporting. And that involves more OIC, but it has implications for health in general. So that talks about report on primary care expenditures. So there are quite, and then there are other ones we're tracking as well. But I think some of these are some of the key ones that either have passed completely or very much alive and making its way through the system. And Obviously, I think the other updates, still as you're aware, we still sort of have an interim leadership, and believe the progress is being made with regards to appointing the new secretary. So I think the process is progressing, and I believe they expect a decision in the next few weeks. So we look forward to welcoming the new secretary soon. Thank you.
Yep. Dave.
Sure. So, a couple of different things to highlight for the Healthcare Authority. We have 4 agency request legislative bills that are obviously being heavily tracked for the agency. The one that's most relevant to the work of this commission is the only one that has not still passed through the entire process almost entirely, which is Senate Bill 5083. That's the reference-based pricing healthcare hospital affordability bill for the PEBCEP programs. We talked about that a little bit earlier today. It is necessary to implement the budget. It was incorporated within both budget proposals from both chamber chairs and passed on their floors. So it is something that we expect to pass in some way, shape, or form. Right now it's sitting in House rules, but there's every expectation that there will be some version of that that does pass this session because it was baked into the original budget assumptions before the budget challenges. The deficit of the state got bigger over the past few months. So sure to report back out on that once we come back in June. The one other bill that I realized I just had to check my calendar as to the last commission meeting. I did just want to highlight the PEBCEP consolidation bill never made it out of Senate Ways and Means. That was not agency request legislation bill, but we had talked about incremental transitional steps, and one of those that had been talked about here was the consolidation of the PEBCEP program. So that was Senate Bill 5086. It had a hearing, but it didn't go anywhere after the hearing the Senate, and it didn't have its companion bill didn't have a hearing in the House. So I did just want to highlight that as it kind of directly relates to conversations we've had here in the commission in the past. Like every other part of government, we are awaiting the active negotiations between the chambers. There are many pieces that are within the Healthcare Authority's budget that have are subject to negotiation and still, that includes impacts on Apple Health expansion, 98 funding, service reductions and provider reimbursements, especially in the Medicaid and behavioral health setting. And as was alluded to a few minutes ago by Ross, the funding for this very commission and its work. So there's still a wide range of things that could happen to the budget that we're all waiting for. And then last 2 more things. I'll shift to the federal government for a moment. There are a lot of questions that are coming to the Healthcare Authority about right now, like what's happening on specific issue, why? The answers are right now that there really aren't a lot or any specific policy or rules that have actually been proposed or published out of the federal government or through CMS that have specific response or analysis to discuss publicly at this point. So there are a lot of statements that have been made, but they are not rules promulgated or policy statements out there. So to the extent people are asking what does X or Y mean, right now, there are not formal proposals that are able to be kind of reacted to. At the same time, our agency has begun producing kind of on a monthly basis an update about summary information on Medicaid, the program, the enrollment by congressional districts, all sorts of demographic breakdowns of different, some sizing of various potential cut scenarios. So there is a piece on HCA's website that has a fabulous presentation that kind of walks through the core of the Medicaid program and at least some of the moving parts that are at least some level of more formal discussion. So it might be something that people find helpful. I know I found it helpful as a refresher since I live a little bit more in the commercial world. So just wanted to highlight that that's how, and there are briefings that are happening with congressional staff and the governor's office related to at least the nuts and bolts and general state of our state Medicaid. That's what I've got.
So keeping up with the federal theme, while there have not been proposed on the Medicaid side of the world, the federal government put out a proposed rule on March 10th. Comments were due on April 11th related to the individual market. And Laura Kay can talk a little bit about all of the things in the rule that would require the health benefit exchange to change the way they offer individual health plans. The issue of primary interest to the Office of the Insurance Commissioner was we include gender affirming care in our essential health benefits benchmark plan. The rule proposes to prohibit the inclusion of those services in state essential health benefits benchmark plans. So the bulk of our comments back on that and a lot of other people's comments were that not only is it not good policy, it is arguably not legal. So that's where I think most of the attention is right now. The federal government has said that they want to finalize those rules as quickly as possible and apply them to plan year 26, which is quite a challenge given that the insurers have to file their individual market health plans with us by May 15th. So more on that. In terms of the state legislature, Dr. Shima mentioned the governor has signed Senate Bill 5084, which will give OIC the ability to require insurers to report the same primary care expenditure information that they already report for Medicaid and PEB and SEB. So that way we'll be able to see primary care spending for over half of the population in the state. So, and that just like flew through. It was really nice. And then there's another bill, Senate Bill 5579, which is back in the Senate for concurrence, that many of you have probably heard about contract disputes between insurance companies and providers and how they get quite nasty. And there are letters to the editor and letters to patients that get patients all worried about whether their provider is going to be in their health plan. And so this bill basically sets a level playing field between insurance companies and healthcare providers in terms of how they communicate out about pending contract disputes. And then the last one I'll talk about is House Bill 1432, which is back in the House for concurrence. And that is behavioral health legislation. There were federal behavioral health parity rules that were adopted in September of last year. It will integrate those federal rules into state law so that if they are weakened by the current administration, we'll still be able to enforce them in Washington. And it has changes around how insurance companies make decisions to approve different kinds of behavioral health services. So those are the big ones. There was a prior authorization bill that did not make it through the legislature. That was Senate Bill 5395.
Laura, Kate, did you get the heads up on this, on the report out?
Yeah, thanks, Vicki. We're at the Health Benefit Exchange, we're really focused on the access and affordability risks and challenges that are really present and incoming for the exchanges, nearly 300,000 qualified health plan customers. I'm sure Joan has talked before that we're very much watching and anticipating that enhanced premium tax credits that have been in place since 2021 will expire at the end of 2025, which our estimates estimate that when that occurs, that nearly 80,000 exchange enrollees will no longer be able to afford their health insurance and will drop from the exchange. And so we're working on a variety of mitigation tactics with our partners on that. The first one that we're really focused on, specifically in the state legislature, is the funding of state premium assistance program. So this is called Cascade Care Savings. It is premium assistance for customers who are up to 250% of the federal poverty level. So folks who are making like $35,000-ish a year. We are anxiously awaiting legislative budgets. We have seen stable funding from previous years for plan year 2026 in all three proposed budgets that have been released so far. So we're really we're watching that, and that's our number one priority. We're also really appreciative of OIC's emergency rule that hopefully will aim to stabilize the market, particularly for those 80,000 customers who would otherwise drop. And so we're working here at the exchange to really make sure that those market changes are navigable for our customers, who will see some changes in plans and premiums, and also for those who are assisting customers with enrollment in 2026. Jane mentioned the proposed rule from CMS. The exchange provided public comment along with, I think, about 22,000 others last week. The proposed rule for the marketplace, the stated intent is to increase program integrity and to increase affordability. Our assessment and public comment really focuses on what we believe the actual impact would be if the rule becomes final, and that really I think in summary looks at no change to Washington State's program integrity. We already have quite a lot in Washington State. We'd see decreased access, decreased affordability, some harm to the risk pool, and more. I'm happy to provide information about what we provided in that public comment. And then finally, we are, from an equitable access to coverage perspective, we continue to be focused on any risks to the exchange's 1332 waiver, which is providing currently qualified health plan access for those who are not legally present. And there are risks that we're anticipating to the continuation of that waiver, but our really guiding principles are that we're going to maintain the waiver as long as we can. We're going to protect the privacy of all exchange enrollees, and particularly these enrollees. And then we're exploring and planning for alternative coverage pathways, including having that state premium assistance as folks are eligible for it to follow this population. I think those are the big ones for us.
Thank you, Lord Kate. Omar was ever able
I don't
to
think
join.
Omar joined us.
Right, does anyone else have any updates they want to give?
I think some of Mohammed's hand up. It was
Yeah, it
Mohammed?
was.
Did you have something, Mohammed or Nicole?
No, I just wanted to ask the folks at HCA, do we as a state have protection from what is going on the federal level? Because any minute now, everybody's worried that a lot of the stuff that we have, we might lose because of the federal government. Just gonna, opt that question in for the public who are listening to.
I think we're all anxiously awaiting exactly how the federal government structures. I mean, the way I've been trying to answer this is that, there are a lot of possible ways that the federal government could attempt to assert policy changes, and our agency doesn't want to contribute to the rumor mill. We will wait for specific policy proposals to react to publicly.
Comments or updates from commissioners? I would just add from the Indian healthcare delivery system that our tribal leaders have been in Washington, D.C. like nonstop, I think, for the last couple months. In conversations with, if you can call them conversations, when only one person asks questions. Nobody answers them, but with Secretary Kennedy about the Indian health delivery system, and he has made some commitments to make sure that Medicaid and Medicare work for the tribes or for Americans, Alaska Natives, and being positive, but the next team that they've had a little bit. So, we have the traditional Indian medicine waiver in the budget. That means we then would need to apply for a waiver with CMS, so got some kind of a commitment that he would be supportive of that. So the interesting talks also, he also, when we talked about workforce shortages, when our leaders talked about workforce shortages, mentioned that they were thinking about doing a pilot for AI workforce, so using Indian health clinics as the pilot project for use of AI nursing, which was not well received. And also moving staff who have like leadership at CDC have who've lost their jobs, moving them to Indian health. They haven't practiced in a long time. Those are some things that are a little concrete that we hope to. However, I think it's really important that we continue doing this work, because I think now more than ever, it's trying to get universal healthcare in Washington State. I mean, if things are a mess at the federal level, we gotta depend on ourselves to figure out how we can move this work forward. I look forward to us getting our new legislative advisors, like Mary said, working on that. And what we can do in the next year as far as recommendations. So thank you to each and every one of you, and for the time you put in this. It's really important, and I just can't thank you enough. And to the people who come and listen and give public comments, your time and effort is important too, and especially to the staff who are working on this every day while we're working on all their other things. So thanks everybody. We will see you in June 11th.
June 11th. So Wednesday, not a Thursday next meeting, 2 months from now. Yeah. Okay.
Is that it always, is that the one?
I think that's the one we're trying to do, although I won't be there, so I don't know.
We might possibly be at OIC, or we might wait till Jane comes back. So thank you. Take care.
Everyone.